thank you for doing this today.
Yeah.
Thanks for coming on the beat. Dr. Sanjay Kurani, Hospital Medical Director.
Correct.
Of Santa Clara Valley Medical Center.
That is correct. How you doing, Nick?
Good. How are you today?
I'm well. Thanks for having me on today. We're always in the hallway talking.
Yes.
And I always feel like we're doing a podcast in the hallway. So here we are finally doing it. Huh?
Getting it on the record.
I love it. Great.
I'm so excited to do this today because what we're talking about today is, some of the research that's gone into ABCM score. We'll get more into that COVID research and the way that trends are happening with variants. I'm not the medical guy. That's your job. So I'm excited to get to hear from you today, ask questions, and really help to even further educate the public more on all of the wonderful research and care that's coming out of our hospitals and clinics here at Santa Clara Valley Healthcare. But yeah, I'd love to first get to know you a little bit.
Sure.
And hear about your backstory in coming to this hospital.
I was born in Boston, actually, and came out to the Bay Area when I was a kid. And my journey towards healthcare, it's a funny story. I was this like vegetarian kid, right? Grown up Indian. I didn't have, we didn't eat much meat in the house, actually. None, being of Gujarati descent. And I remember just being this skinny kid and reading every single book on how to be more athletic and gain weight and gain muscle. And that actually was the beginning of me getting very interested in nutrition and physiology and things like that. It started that way. And ultimately, I went to Berkeley for undergrad and studied molecular cell biology and continued just reading more and more and more about sports physiology. I was rowing crew for their lightweight crew over there. And so did start eventually adding more fish and chicken to my diet there. But really, really got interested even more and more into just how the human body works. And I think naturally what happened is I wanted to go into medicine as a result. It just made sense to me. But interestingly, at the time I was taking some business courses at Berkeley, and that came very naturally to me as well. And so ended up going to USC for med school. And while I was at SC, I remember my dean, because USC LA County Hospital is the largest, at that time was the largest public hospital in California. And I remember, we took care of a very, very vulnerable group there, the east side of LA. And I remember my dean coming up to me when I was a medical student and saying, you know what, just spend 1 year of your training at a public hospital if you can, like you're after med school, because that's the genesis of medicine, basically. It comes from areas where, from the ground up, charitable organizations, people who a lot of times volunteer their time to be able to help others. That's the genesis of medicine, if you think about it. The roots, it should be coming from that. And he felt like a public hospital encompassed that. And I applied to Santa Clara Valley Medical Center for my internship and residency, just thinking I would do at least 3 years here at a public hospital and then go from there. And well, Nick, here I am 25 years later. So obviously had an incredible impact on me. Doing my training here, just seeing how the hospital was run, the management of the hospital, just the incredible support this hospital gets from a lot of the leaders, including the community, or excuse me, the board of supervisors, as well as the community, how much the community really relies on this hospital, but also supports it too. So, and it being a teaching facility, it just has been great for me to be here. And then, of course, taking over as hospital medical director, that's kind of a little bit of that business side of me, how to keep operations going. And this has been a great place for me to grow and learn.
What a wonderful origin story,
yeah,
if you will.
Yeah.
With your permission, we'll have to share your ID photo, since you have always had the same ID photo.
I have.
Right?
You want to see this? Oh, wait. It's on my... Here it is.
Yeah, this is amazing. Truly,
So
this
is me
place.
so this is...
We'll get a close-up of that.
Yeah, there you go. That's me as an intern right there.
And I said, we can update your photo. And you said, no, we're going to keep it the same.
No, I'm going to keep it the same. The plan is to keep it all the way until I retire. And it's a funny story. I thought about, having a new a badge like 10 years ago. And I was going to get rid of it. And I just thought to myself, no, another year. And then it just became a joke with the residents because I'd be able to, every time I'm on the wards with the house staff, the residents and interns, this is my way of connecting with them. As I used to be one of you a long time ago, and I know what it's like just doing those long hours. It's a rough road, but definitely well worth it.
Well, it's very inspiring to see all the years that you've put in and your passion for being here at the hospital just continue and probably grow stronger as well. Like I said, today I'm excited to, get on the record all of the things that we've discussed many times in hallways, talking about, the pandemic and the research that went into it behind the scenes, looking how we were going to care for patients in the heart of this pandemic at the beginning all the way to even today. But again, like I said, this podcast was really geared towards highlighting research, highlighting patient care. And today we're, combining both of those.
Yeah.
And so where does it begin?
Well, I remember when, COVID started, we were hearing about what was happening in China, and then ultimately in Europe, and then eventually, in New York. And so, even to this day, it traveling kind of from east to west, you can almost look a little bit in a crystal ball as to what's going to happen. A lot of times when you're looking at what's happening as you go further and further east, specifically, we look at the UK a lot of times. We saw what was going on with South Africa before Omicron, so you can almost see what's happening when you look out east. And so when COVID first hit in March of 2020, we were bracing for this tsunami. We didn't know what this tsunami was going to look like, right? Novel virus. Nothing in any of our med school books to really describe what we should prepare for. But what we knew is, it was hitting China very hard. And then eventually it was hitting Europe, especially, I think it was the Lombardy region of Italy. And then it hit New York. And so once it hit New York, I felt like, I had a chance to speak to some of my colleagues who were there so we could prepare over here. Because we're kind of flying blind. And I spoke to one of the medical directors of a hospital over there, and I said, what are you seeing over there right now? Is it as bad as they say? And he's like, what's interesting is it's unlike what they're describing in Wuhan and in Lombardy, where you're really thinking it's these kind of older patients that are decompensating, especially in Lombardy. He's all, what I'm seeing here is a lot of folks who are in this vulnerable group, a lot of them who are just a little bit obese, not terribly obese, a little bit obese, many who are African Americans, those who are brown population as well, and a lot of men. Those are the three things he said. And he's like, and in addition, it's not these people that you think of that are like 85 years old that are dying. We're seeing a lot of 50 to 60-year-olds as well. I said, that's really fascinating because that's a lot of our population here. And especially the brown population here in Santa Clara County, which would be a lot of our Hispanic Latinx population here. And I remember when it first hit here, bracing for potentially the same characteristics coming in, but not really knowing, are we going to get people who are kids that are sick coming in? Are we going to get adults? What are we exactly going to get? And the hardest part, Nick, to the whole thing is we really didn't have something that would tell us a person's particular risk of getting really sick, right, when coming in, and how many beds we'd need and so on. So what was fascinating, one of the first things we did, now we had opened up our command center. We have this thing called our medical branch, which is structurally part of the command center that helps with policies, what type of testing we should be doing, what type of PPE we should use, isolation, whole bunch of things. It was a bunch of medical leaders that we put together, basically almost like a think tank, looking at the literature, looking at guidelines from the CDC and Public Health Department. And early on, we didn't have those guidelines yet, right? We, as I said before, we're still flying blind. But what we did have was a lot of data already in the hospital. And so what we did is we teamed up with our analytics team so that if we had a question, could we find the answers in the data very early on before academia could come out with a lot of the answers or waiting for CDC, Public Health Department guidelines. But one big question we had was, what is the risk factors for getting really sick with COVID? And that would help us not only prepare with, how many beds we'd need, but really at the very front end, who needs to be admitted, who doesn't? Are we help us use our resources properly? And, when I'd heard about a lot of these patients who are Black or brown, vulnerable, many of them with a higher body mass index, many of them being male. What we decided to do is go and look at how many people are within a month, 2 months. We were able to look at all the emergency room visits. And what we did is we kind of sliced and diced the information, looked at different risk factors, and we were able to come up with a score. And that score, this risk score, was ABCM, which is age, body mass index, comorbidities, and male. And very similar to what we were seeing when I was talking to that director over in New York. And, we just, we took this score and we looked at what the outcomes were based on that score. And, it was a little more complicated as to how we created the score. But basically, just to summarize it all, once we were able to find that this score could help predict, we were able to look at based on if they had a score of 1, 2, 3, or 4, right? There's 4 elements, A, B, C, and M. Age over 60, body mass index over 30, comorbidities, which is chronic conditions such as congestive heart failure or kidney failure, diabetes, right? And then male. And then you get a point for each. And what we found is anybody who had a score less than 3, 2 and below, had an incredibly good prognosis in terms of mortality. And those who had a score greater than that, especially 4, did not have a very good prognosis. And what we were able to do in the emergency department to help us was the electronic health records. Right when we register, our EHR, electronic health records, let's say you came in, Nick, and you had COVID, the machine could automatically, you already have your age in there. If we took your weight, you have your body mass index and your height. Your chronic conditions are probably on the chart already, and it can pull that. And then your gender is on there too. We could actually have the machine create a score. And what we did was we had that score available for those in the emergency room when they're caring for a patient. And it would be right there on the chart for them to see. And if they were COVID positive, depending on what that score was, of course, if they were really, really sick, you would admit them. But if they were, doing okay, you could use that score as a tool to help you decide, do they need to be admitted or not? And of course, supply-demand mismatch, we only have so many beds available. And that was a great utilization of that tool. And as time went on, as the months went on, we were able to continue to validate this tool. And we continued to use it throughout the entire time, all the way through even while we had the vaccination campaign going on. So we used it during that first surge that we had in March of 2020 to help us. And then what we were able to do is continue to use that score, that ABCM score, once the vaccines came out. You still had people who had what we call vaccination breakthroughs. They, especially even during Delta, which was that summer of 2021, right? If you remember. And when they had those breakthroughs, we saw that the ones who did the worst still were the ones who had a higher ABCM score. So it was really fascinating how that score continued to help us even after the vaccines. The vaccines were, of course, initially with that first, with the original virus, incredibly effective. But as Delta came, we saw breakthroughs. but we still saw the ones who were the highest risk were still the ones who had the higher ABCM score.
Well, this is just all so fascinating, and the way you lay it out is just really easy to grasp and understand. And so going back to when you first spoke with your former colleague in New York, you're talking about what you're seeing, this potential wave that's going to come. You talked about the way that academia comes up with like a plan. Are you at this early stage before you maybe even had a chance to come up with this scoring system? Are you sharing this information with the CDC, or do you come up with this score and then share it with them? What type of ongoing communication is it from the beginning of looking at this data to when you have this score in place?
Yeah, I mean, this score, we kind of it was homegrown here. And we didn't really have a chance. We had a chance to publish it into different journals, but we really didn't have a chance to connect with the CDC. And I think that's an opportunity, quite honestly, going forward, is I think where the CDC and the local hospitals can do better is being able to share some of that data with them, so that in a quicker fashion, they're aware of what's going on, rather than waiting for the information to trickle down to them. So I think that there's incredible opportunity to share this data with the CDC, whether it be COVID or any other pathogen that we're dealing with going in the future. There's just a treasure trove of data out there. It's just connecting the right people and asking the right questions.
Well, it's just so inspiring too to hear that, like you said, this research homegrown here, right here at the public hospital system in Santa Clara County. Part of my job when I was hired here in multimedia communications was to help highlight all of the amazing things that happen here. So this is just further evidence of that. When you talk about ABCM and you are developing this, is the purpose first to, influence what's happening as far as lockdowns, things like this, to show the CDC, for example, what you're finding? Or is it to educate the public about how they can look at their own risk factors? What's the primary goal?
Yeah, I think initially, honestly, it was curiosity. It was just trying to recognize who's higher risk, right? Because we just didn't have that information yet. And then later, like I said, it became a tool to help us, on the front end decide, okay, this person has it. What's their risk of being admitted? Are they safe to potentially go home? Should we observe them for a day if they have a higher risk? It was used as a tool. One more place that was used is we actually saw those who had a higher body mass index, they were actually prioritized to actually get the vaccines early on. If you recall, there was these priority tiers, age and body mass index and immunocompromised. Almost a lot of the features of ABCM started developing, right, in terms of how they were going to tier this for prioritization for the vaccines. I think where the opportunity has always been, when you look at these scores, for people to recognize, look at the components of that ABCM score. Some of them are not modifiable, right? Your age or your gender. But your body mass index and the chronic conditions you have are modifiable. And I think when it comes to your body mass index, it's not as simple as saying lose weight, because we're all built differently. There's no doubt about that. We all need to find better ways to be able to adjust that body mass index to a healthier range. And I think that's where a huge opportunity lies in our population is if we have the level of obesity, quite frankly, we have and the related health issues with obesity, whether it be diabetes or high blood pressure, elevated cholesterol, all of these things. You're going to have the risk associated with that, but we're recognizing there's additional risk from COVID. And so that's an area that I think really should be explored. Is we talk a lot about how to mitigate being, using vaccines and therapeutics and social distancing and masking, but the power is right there within the individual to be able to risk modify. And your body mass index, these other, if you're diabetic, that's high blood pressure. These are examples of what you can go and modify yourself. I think it's empowering for the individual to know that they can reduce their risk with things they can do on their own, rather than obviously the other methods we have to reduce risk right now, like the vaccines and so on, which are very important. But you have the power yourself to modify your risk.
As far as ABCM scoring goes, and modifying your risk, let's say somebody has a low score, were you still seeing some breakthroughs or some anomalies, outliers of people who had a lower score still contracting, a bad case of COVID?
No, you definitely, it's not as often that we saw the mortality with the lower scores, but they did occur. And, those are cases definitely worth studying more. And whether there's additional ways to be able to identify who's at high risk beyond just these conventional risk factors that we talk about, I think that'll be important. I always say now you could even do, your risk factor should include an I in there. So it should be ABCMI. And so ABCMI would be age, body mass index, comorbidity, male, and what's your immunity status, whether it be natural or vaccinated. And that can even further help identify if you're not immunized, then you're even higher risk, whether it be natural immunity or vaccine-generated immunity. And so you could identify now that we're post-vaccination, post-Omicron, where so many people have gotten infected, you could probably run the data even further to modify that score to A, B, C, M, and whether you have immunity or not.
If you're adding that I, whether it's immunity through vaccine, immunity through having caught COVID-19, people getting vaccines sometimes have breakthrough cases. So how do you score it if immunity is kind of on a sliding scale?
Yeah, right now we're still learning a lot, but there's no doubt part of the reason why COVID was so dangerous to us was it was novel. It was novel to our immune system. And so much of the damage that occurred to our lung was beyond just the pneumonia that the virus created. It was the friendly fire of our own immune system that went haywire because it hadn't never seen it before. So it was basically send all your troops out there to battle this, Army, Navy, Air Force, Marines, everything. And then while it's battling, it's creating more inflammation, it's causing more damage. Now that we have more immunity, and it's not as novel anymore because we're not naive to it. You're not seeing, when we see these cases come to the hospital, you're not seeing as much what we saw before, which was this, we call it this cytokine surge and the immunity just going haywire, and seeing all the results of it, and the damage of it as well. You still have your vulnerable that are at risk for that. There's no doubt. But given the amount of population immunity we have right now, I think this is why all the conversations towards going endemic is going on right now.
That has to be encouraging to be at this place for sure.
It is. It's very encouraging. We're seeing what we call a decoupling now, so that's important. So the way I was able to risk stratify people using the ABCM score, and that was really helpful, using the data to help us figure out how to risk stratify. We've been able to see kind of the evolution of this virus and its severity, and where immunity has helped us as well. We're in this kind of post-Omicron, post-vaccination, post-high immunity state right now. And with it, what we're seeing is this decoupling. And a lot of people are talking about this. They've been talking about it since Omicron came. And so I'll give you an example of decoupling. When we first had Delta, and patients were coming in with COVID, and that was that summer of, it was summer of 2021, I want to say. What we found is of those who tested positive in the ED, almost 10% went to the ICU, roughly. I'm just giving rough numbers right now. When Omicron occurred, we were in a much better state where we were more immunized, vaccinated, and also the virus itself was different now, and the severity was less. And so we saw this decoupling between whenever the rates of infection went up, what was the hospitalizations and ICU cases doing? And previously, you'd see them go up together, right? But now you saw a little more decoupling between the rate of infection and the amount of people who needed to go to the ICU. And that was very, very encouraging. That number dropped significantly. And as we went into this, BA4, BA5 wave here, summer of 2022, we're seeing even further decoupling, which is very, very encouraging. And I think we need to continue to follow that, this decoupling that we're seeing, and making sure as the new variants come out, we're all going to be at risk for infection going forward. I think we will. This doesn't look like it's going to completely go away. The question is, how much havoc it's going to create. And if we have a situation where you see this decoupling going on, that's encouraging. You still have those who are high risk that still need to be protected. It's that simple. So I think all of us have this sigh of relief that we're looking at this more endemic phase, and you're seeing this decoupling and higher levels of immunity, et cetera. But we can't ignore what our job is, which is to take care of those who are vulnerable and make sure we do come out with therapeutics that can help them. And, those who have the high ABCM score, don't have immunity, or very highly immunocompromised, we just got to make sure that we keep working on them, and not just, everyone used the word COVID fatigue. I think that's a bad term, COVID fatigue. I actually don't like that term. I think a lot of the fatigue is just a lot of people get really confused by so many different things being told to them, right? How many boosters do you need to take? Does Paxlovid work? Does it cause rebound? Should we mask? Should we not mask? What's the hospitalization doing? Just people are fatigued by hearing so many messages. I think they want to hear a very, very clear message. And I think the clear message is right now, yes, we are in a more favorable phase, but we have to make sure we take care of those who are vulnerable as well. It's our duty as Americans.
Now that we're talking about the variants a little bit, how did you use the ABCM score I know we've talked about modeling out things to come as far as variants and things like that shifting. Is that where the ABCM score is applicable, or is
No,
that
I think separate? ABCM was very helpful for us early on, pre-vaccine, even after the vaccines when we had Delta. And I think it's still helpful in, as we go forward, and we'll have to study this more, of who's going to benefit from boosters. But likely those who are higher ABCM scores, immunocompromised, will probably benefit from the boosters going forward. Now, what variant is going to come next? I don't know. Nick, none of us know, right? What I do know is we have a lot of immunity out there, and that I think is really important. We also have good therapeutics out there, and Paxlovid is a good example of good therapeutics that we have out there. We have to make sure that we have better access to it as well. Talk about these things like test and treat, just having those type of things available when we do have these surges of COVID that come along, especially focusing on those who are vulnerable. So I think if we have that infrastructure in place, no matter what variant comes along, hopefully we can attack it. We have so many tools right now. Now everyone keeps talking about that next variant. Will it be immunoevasive, meaning it'll be able to dodge your immune system? Is it going to be more severe? Is it going to be more infectious? Yeah, I think we all worry about that, and that's why we are still testing for variants and trying to share information to see what else is out there. But I'll be honest, I'm very, very hopeful, given the level of immunity we have, given it's not a novel virus anymore, that we do have good preventive measures out there, that we do have good therapeutics out there. But again, as a physician, I want to still stress that we still look to our population to be able to take ownership and responsibility upon them to try to modify their risk factors too. That's a big piece of it as well.
Well, I think it's encouraging that throughout the various variants that this research has upheld throughout. And so
Yeah.
That's just amazing that, like you said, homegrown here.
Homegrown here.
Amazing.
And yeah, I think what it taught me is we don't know what's going to come next, and I'm not just talking about, I'm not trying to frighten anybody with novel viruses coming along, but even the ones we already have, the flu. And right now we're seeing surges in something called RSV. And where can we earlier on at the local level, as we start to see, trends going in a certain direction, make sure that we're able to get some of that data out to others to share rather than just a simple phone call and saying, hey, what are you seeing there? How do we share the data? Not just making, phone calls to a friend over in New York and say who's in medicine saying, hey, what are you seeing there? That was helpful. Don't get me wrong. But how do we make sure we're all sharing that data from the local level to the central level and from local to local as well? I think there's a lot of opportunity there.
Yeah. Well, I was going to ask, what is RSV?
Respiratory syncytial virus. So,
Okay.
for most people, it's just a common cold. But what we're finding right now is we're seeing a surge in young kids who are getting it. That during the period of time that we were social distancing, masking, and they weren't able to go to school, of course, we saw very low levels. And now that they're back out into the community, these viruses are making a comeback. And, there's a lot of talk about something called the immunity gap, which is a lot of these kids would have probably earlier on gotten exposed to some of these viruses, built up some immunity. But now they've been pretty, their immunity has been pretty naive. And all of a sudden they're getting hit with all of these viruses all at once. And with a naive immune system, it's going to affect them potentially more adversely. And so we're seeing a lot more cases. We were looking at the amount of cases here within Santa Clara Valley Medical Center. We saw, over a month's period of time, about 20 cases last year between September to October. So very early on, very few last year. Now very early on, those cases are up to 300 we saw most recently. And so those aren't all requiring hospitalization. That's outpatient included. But a small percentage of them are going to require hospitalization. The rest of the country is dealing with this already. Their hospitals are getting filled with a lot of these cases in their pediatric wards. And we're already starting to see that uptick. So that's where, we need to be able to share this information very quickly. We start seeing these anomalies where, wait, we didn't see this last year. How do we quickly share it? How do we get the data out? How do we make sure that we're able to prepare quicker and faster as systems?
So I was going to ask, as we look to the future, as we hopefully don't experience something else like this, at least for a very long time, the way that this was developed, will this influence the way that research is done as a whole going forward?
It's a good question, Nick. I think we always think about research happening, at these academic centers or, government-sponsored research and grants and so on. The big opportunity right now is ever since we've had these electronic health records now, right? We have, like I said, this treasure trove of data. Having more people in the analytics department, more statisticians, so that we have cleaner data, cleaner reports as well, I think could result in a powerful engine of research right at the local level. And I think it's an incredible opportunity for all the local hospitals that serve large populations to be able to ask the right questions and find answers in the data.
I think for people hearing this, I think this is going to be just really encouraging for people in the community who hear that Santa Clara Valley Healthcare has their back in a care sense, but also just in a way that we're looking to the future in order to protect the community. People who will look to this institution as a place to come be a resident, for example. Mm-hmm. I think this is just going to be a really amazing tool for people to listen to and not only look back and say, wow, what amazing research was done here. A lot of tragedy took place, but, we're using, minds like yours to look forward to be able to, maybe prevent some hardships in the future. I think that's just really incredible. So
Yeah, a lot we learned, no doubt. And I think we have to take what we learned and be able to move forward with it. To your point, has been a tough couple of years, and hopefully we can take what we learned, and that's the key, and be able to help us going into the future. And I'm hopeful, Nick. I really am.
That's amazing. Is there anything else that you would want the community to know, COVID related, not COVID related? I know you're just a big fan, having been here so long.
Right now, as understandably, there's a lot of attention on just COVID and the disease, the physical disease. But I think right now that parallel pandemic that we were talking about earlier, which is the mental health effects that this entire pandemic has created, is something that cannot be ignored. I think it's going to need more and more attention. I do. I think we're just seeing the tip of the iceberg of it. And it's important that as a community, we socially start to reintegrate as we start coming out of. We've been out of isolation for a while. I think there's opportunity to better integrate now and have better conversations, healthier conversations. And I think if we can do that, I think it's very important to be able to as a society be able to have these good times together too. I think we've been in these silos and been having these sometimes this vitriol with each other, either through the internet or social media. And there's a way to socially integrate again, have more healthier experiences together rather than virtually together like we're doing right now. I think that's a good first step. So it's me getting a little philosophic, I guess.
Given this past hour, I know that I am even more proud to work here. And so thank you so much, Dr. Kurani, for joining today. We have much to talk about on other topics, so I hope you come back to the beat again.
Thank you for having me, Nick.